Hi everyone, happy to see you all in our online symposium. I am delighted to present a dear colleague and a big researcher that I admire a lot, Dr. Keith Dobson. Dr. Keith Dobson is professor of clinical psychology at the University of Calgary in Canada. His research has focused on both cognitive models and mechanisms in depression and the treatment of depression, particularly using cognitive behavioral therapy. He is also a principal investigator for the Opening Minds program of the Mental Health Commission of Canada, with a focus on stigma reduction related to mental disorders in the workplace. And his research has resulted in over 280 published articles, over 80 chapters, 15 books, and numerous conferences and workshops presentation in many countries all over the globe. He has also been actively involved in the development of CBT internationally and is a former president of the Academy of Cognitive Therapies, of the International Association for Cognitive Psychotherapy, of the Canadian Association of Cognitive and Behavioral Therapies, and currently he is the president of the World Confederation of Cognitive and Behavioral Therapies. Among other awards, he has been given the Canadian Psychological Association Award for Distinguished Contributions to the International Advancement of Psychology. Today, Dr. Dobson presents us with the keynote talk, Critical Adaptations and Online Delivery of CBT for Depression in the COVID-19 Pandemic. Please welcome Dr. Keith Dobson. Such a pleasure to have you.
Well, thank you. Thank you for that very nice introduction as well. It is my pleasure to be here today. And as I understand the scheduling, I'll talk for about 45 minutes or so. And then we'll have a question and answer period. And hopefully we can address some of the concerns that practitioners have with respect to depression. But what I'm going to do today is several things. I'm going to talk a little bit about normal responses to pandemics. So some of the things that we know about pandemics, there actually is a very good book I'll refer you to that was published just before the COVID-19 pandemic about the psychology of pandemics, and helped you to distinguish some of the normal responses perhaps from what we would consider clinical depression. I want to focus this talk also around risk factors. And as I'll say, I'll just tell you now, but I'll say again, we don't actually think that the risk factors for depression have changed as a result of COVID-19, but what has changed is the presence of the factors. So some of the factors have become stronger or more present, and so it's increased the rates of depression, but the risk factors themselves probably haven't changed that much. So what I will then do is focus on the cognitive model of depression and some of the primary interventions we use and see how we can adapt them in the context of COVID-19 with respect to those risk factors. So trying to take into account the best that we know. And then I will talk a little bit again about how we can integrate CBT for depression for digital and online delivery, because of course that really has become a critical feature during COVID-19 because of physical distancing rules. So a number of things to try to accomplish in a relatively short period of time, but I hope that we have some success. Very quickly, and again, most of you watching this presentation will know this, but there is a diagnostic framework for considering major depression, or MDD as we sometimes refer to it. It requires the presence of at least 5 out of 9 possible symptoms for a period of at least 2 weeks. And there are 2 cardinal features, or 2 cardinal symptoms that are recognized, and one of the 2 must be present. When you take into account the fact that there also are some paradoxical symptoms, so for example, you can in some people see less sleep, in other people see more sleep, so different types of responses, and you look at all of the varied combinations of the signs and symptoms of depression, there are at least 945 unique combinations of these 9 diagnostic criteria that can lead you to a diagnosis of major depression. And you could well imagine, for example, that one person has one of these cardinal features and then 4 other symptoms of depression. So they have five of the symptoms and they have a diagnosis of depression. Another person might have that first cardinal symptom, but then 4 other of the 9 symptoms. So these 2 people would only share one common symptom, but they get the same diagnosis. So you can imagine sort of different presentations. You can imagine another person who just has the 5 criteria is diagnosable, another individual who meets all 9 criteria, so has quite a much more severe case. You could imagine someone who just has had the symptoms for 2 weeks, so again, they meet the criteria. Somebody else who has had these problems for a period of years, so the chronicity varies. So symptom presentation, severity, chronicity, age of presentation, these are all some of the diverse factors that affect the way that major depression is presented. So when we think about depression as a construct, one of my arguments would be, in fact, we probably need to think about it more as a series of disorders or a series of different presentations. And in fact, contemporary CBT for depression is focusing somewhat less now, I would say, on the diagnosis per se, than on the actual presenting symptoms that people have and targeting the symptoms or the problems people have that lead them to their depression. The other thing worth noting as a consequence is that not all CBT methods are likely applicable to every case of depression. And in fact, we know that we need a case conceptualization for every person and that we need to target our interventions for that particular person's needs. We also know that there are different stages of depression. So this slide tries to represent the idea that people have an onset of a depression, they go into an episode, the first episode that's identified on the left side of this screen. Hopefully they get treatment or they have a spontaneous recovery. So they go below this orange line that represents the diagnosis, then they become no more depressed. We actually recognize 2 levels of getting better. One is called remission. This is where the person loses the diagnosis. And the other is recovery, where the person not only loses the diagnosis, but is able to stay well for a period of time, usually defined as 2 months in the research. And we know, in fact, that people that have a longer term recovery and a more complete recovery actually tend to have better long-term results. People with more just a short-term remission or less well-established offset of symptoms are at risk for relapse and recurrence. And we know, in fact, from some of the epidemiological research that's been done, that if a person has a first episode of depression relatively early in their life, let's say late adolescence or early adulthood, the average person will go on to have a career, as we call it, of about 5 or 6 episodes over the course of their lifetime. So recognizing and treating early signs and symptoms of depression is important for their long-term health. We also know, and again, this is emerging literature, that the rates of depression probably have started to creep up with the pandemic. So again, there are different estimates of rates of depression globally. In general, we look at rates of about 4 to 6% in a given year. Women are at increased risk of depression in most countries of the world. In some countries in the Western hemispheres, typically it's about 2 times the rates of depression as for male. But we also know that there are good estimates now that rates of depression have gone up over the last year. This particular study on this slide is out of the United States. And what it does is it compares estimates of depression just before the pandemic using a constant measure. This is the PHQ-9, Patient Health Questionnaire 9, and looking at estimates of different levels of depression from not at all through severe depression, and then looking at how these have changed over the last year. So there were 2 studies that were done in 2017, 2018 with about 5,000 participants. And if you look at the moderate to moderate severe range, in fact, you get an estimate of about 6% of people with major depression at that time. If you look in the last year, these are the red bars on this particular slide, based on a sample of about 1,400 participants, the estimates look more like about 20%. So rates, we're saying in general, have gone up about 2 to 3 times. We see different estimates in different countries, partly based on the data, the way they're collected and the form of analysis. But we know, in fact, that rates of depression have gone up significantly. And it's not surprising when we look at, as we will in a minute, the risk factors for depression. So let's turn to that topic of risk factors. Again, models of depression have evolved dramatically over the last 20 years. We know much more now than we did 20 years ago, for example. And our models of risk and resilience, so factors that might reduce the risk of depression, have again led to more discovery, I think, about the range of factors and the relative importance of different factors. Most contemporary models of depression use what we would call the biopsychosocial approach, which is essentially the confluence of different biological, psychological, and social risk factors that might increase the likelihood that somebody is going to suffer from major depression. The next 3 slides will highlight some of the major results from this research over the last number of years. So in terms of biological risks, again, all of the factors that are named on this slide are evidence-based or data-based risk factors for major depression. So we know, in fact, that there is a genetic risk for depression. I'm not going to go into the details just because of time, but there actually is a moderate genetic risk. There's a familial transmission risk over and above the genetic risk. So living with people who are depressed or living with families that have depression in them increase the risk over and above genetics. There are neural structures that have been implicated in the likely onset and maintenance of depression. Neurotransmission models have been around now for at least 50 years, and we know quite a bit now about the neurotransmitters that are implicated in the onset and maintenance of depression. 3 I want to highlight here because these are relevant to the work that we do as CBT therapists are sleep dysregulation. And sleep dysregulation, in fact, is one of the earliest warning signs for onset of major depression. But it's a process that can actually be implicated biologically and can also be treated psychologically using psychosocial intervention. General arousal, system arousal, as many of you would know, many people that suffer from major depression have a history of anxiety disorder or anxiety, significant anxiety. In fact, it's been estimated in North America that approximately 50% of patients who end up being diagnosed with major depression either do or did suffer from an anxiety disorder. So there's a high concurrence or comorbidity between these conditions. And gender. And again, there's a series, of course, of biologically related gender issues around hormonal cycles and the postpartum period, where again, women are at particularly risk. And there are interventions that have been developed or adaptations of CBT for postpartum depression in particular. So again, these are all factors that we know do have an influence in the risk of depression. There also are now a number of well-established psychological risks for depression. And again, most of you, I presume, will know most of the factors that are on this slide, but core beliefs or assumptions that we hold about ourselves and the world can make us vulnerable to depression. We know there are information processing biases associated with depression, and in particular, of course, excessive focus on negative information and disattention to positive information. General pessimism, negative explanatory style or attributional style, if you want. Some people would call it that. So the way we make sense of failures and the tendency for people who are depressed to blame themselves in particular. So an internal blame or internal attribution. Rumination is definitely present for many people with depression. So they think about past failures or past problems they have and don't necessarily take action or less likely to take action. And then avoidance, both avoidance, problem solving, so not approaching problems, but rather stepping away from them and again, engaging in rumination perhaps, or potentially even leaving difficult situations using avoidant or escape behaviors, some that we also see in anxiety, which again is part of that comorbidity or co-relationship. Social risks. We know again that there are a number of factors outside of the individual that increase risk for depression. So parental psychopathology, negative parenting style, so excessive use of force, abuse, neglect, of course, are certainly factors that increase the risk for later depression. Negative life events, loss and unemployment in particular. I'll just mention those. And again, I have to highlight that in the pandemic, many people have suffered significantly increased rates of loss. And loss can take a variety of forms. It could be the loss of physical functioning. For example, a motor vehicle accident that leaves you paralyzed or unable to do the things that you used to do. That can be a form of loss. But it also can be loss of employment. And of course, rates of unemployment have gone up dramatically in the last year. It can be loss of social contact. It can be loss of relationships, for people that have actually suffered the death of a loved one, for example. So loss can take various forms, and rates of loss, if you look at them sort of simplistically, have gone across sort of different types, have gone up dramatically in the last year. So again, this is an important factor. Couple and relationship issues. There's good evidence now that because people are forced together and don't have as much contact with others, that rates of domestic violence have gone up, and people are more or less stuck together. They have more difficulty getting away, for example, and so again, this is an issue that can increase rates of depression. Low levels of social support. It's been known for decades that social isolation, social rejection, social disruptions of different types increase the risk of depression. And of course, with the pandemic and with physical distancing regulations, we've had significant amounts of increased social distance. And so again, this is certainly a risk factor. And then finally, I'll just mention reassurance seeking and negative feedback seeking. So this is the tendency to look for information that might help you to feel better, or potentially also look for information that's going to confirm your beliefs or biases. So looking for social support. And there's certainly a lot of reports in North America, again, of people doing things like what's called doom scrolling. This is an English term, but basically it's an excessive focus on information from the networks, from media, for example, or social influence networks, focusing on the negative. So again, it's a kind of a social support system that builds on negative information and negative biases of attention. So this again is another social risk. So the bottom line is that, again, a number of the risk factors we know for depression still exist in the context of COVID-19. And in fact, some of these are significantly exacerbated or made worse. And so it's not surprising to me and to a number of other people working in the field that rates of depression have gone up. I should also mention, of course, rates of anxiety have gone up for much the same reason. Because a lot of the same risk factors that we know for anxiety disorders also have become more prevalent. This is that reference I talked about earlier. So this is an author named Stephen Taylor. And just at the very end of 2019, so just before the pandemic began, he published a book called The Psychology of Pandemics. So it's a very timely book. And he talked about in the book some of the features of pandemics, some of which I've just highlighted. So uncertainty, confusion. So it helps to explain why people go looking for information to try to reduce uncertainty. Routine disruption. So we've had significant disruption of people's sleep cycles, work cycles, and again, sort of some of the issues around regulation of eating, sleeping, and so on, which are important features of pandemics and which feed into depression potentially. Losses, as he talks about wages, financial hardships, loss of social contact, so social isolation, potential illness, hospitalization, loss of loved ones. So again, the theme of loss coming up again and again. Some of the other ones, like the shortages of food and medicine, healthcare system, are probably not unique to depression, but certainly there are features there. We also know about disproportionate effects. And again, it is unfortunately the case that people who are in disadvantaged groups to begin with have increased risk of depression. And unfortunately, again, pandemics differentially affect people from disadvantaged groups. So low socioeconomic status, low education, for example, are individuals that have increased risk for various problems, and it appears increased risk for depression. And then, of course, lack of clarity. As we know, we're living in an uncertain world right now, and the continuation of the pandemic is not healthy for most people's mental health. So, how do we summarize all this? Basically, depression is a complex disorder with many different presentations. Symptom presentation, it will vary a lot depending on where we are as a particular individual. There's probably, again, like I say, not one model for depression, but there may in fact be multiple risk factors that we need to pay attention to. And for an individual who presents with major depression, we really do need to do a case-specific case conceptualization to understand what the factors are that have led them to experience depression, and then to target those factors, those risk factors, to try to ameliorate or treat the depression. So let me turn to treatment then. Cognitive therapy model. This is one presentation of the model. And of course, again, you would know that there are many of them. And I won't go through this in great detail. There is a reference at the bottom of this slide if you are interested in reading more. But basically, it says that there's an interaction between our core beliefs or our assumptions and beliefs and life events that then leads to changes in our information processing, and in particular, the likelihood of looking more at negative information, engaging in cognitive distortions, and sort of selectively focusing on the negative and disattending to positive information. And it's this process that leads us to feel depressed, to potentially avoid, to withdraw from society, to become less engaged, and so on. And once we start to have this cycle of negative thinking, feeling, behavior, these tend to reinforce our core beliefs and our sort of information processing styles. And they also lead us to change our life by perhaps engaging in avoidance or withdrawal. So for example, if you start to think you're less attractive socially, and so as a result, you start to feel badly about yourself and maybe take less care of yourself, you might then tend to withdraw somewhat from social relationships. And having withdrawn from social relationships, that might tend to reinforce your belief about not being socially attractive or not being desirable by other people. So there's a kind of a vicious cycle or feedback cycle that can often emerge and lead to further depression potentially. So the information processing perspective within CBT is dominant. Certainly the dominant cognitive therapy model of depression tends to focus on core beliefs and negative information processing, cognitive distortions often. But the reality is, again, that many people actually face hardships. And in the context of the pandemic, we know that, again, like I said, a lot of the risk factors have actually become stronger or more prevalent. So it's not that surprising in some ways that our core beliefs are being activated and our negative thought patterns are also being engaged and depression rates are increased. So when we think about the treatment of depression, we actually have a series of different kinds of interventions that we can use that we know, again, tend to benefit people with depression. And what I've done is I've broken these down into sort of three different types or categories of interventions. There are interventions focused on behavior, which I'll talk about here in a moment. There are interventions focused on negative information processing or cognitive distortions. And then there are interventions focused more on core beliefs. And I'll give you some of my thoughts, at least, about which interventions are most recommended during the pandemic. So, when in general do we use behavioral methods with depressed people? We do it when they're dealing with external life issues. So when there's a real problem basically to be solved. And that certainly can be true in the context of COVID-19. So we know, for example, that people may have lost their job and so they need some kind of employment or income. So this is a real life issue. If there are skills deficits, And again, I would argue that in the context of COVID-19, there's no reason to believe that people have particular skills deficits, but they may need to engage in the skills that they didn't use before. Specific behavioral problems. This is a real area of importance, I think, because we do know that sleep for many people has been disturbed. We also know that many people have either changed or stopped their regular exercise. So levels of sedentary activity have gone up dramatically. And so one of the things that certainly I'm recommending for most people is trying to get back to regular sleep cycles and regular exercise. I'll talk more about that in a second. We know again that many people are suffering behavioral restrictions and avoidance. We know generally can be a risk factor for depression. So one of the things I've been saying, for example, throughout the pandemic is that even if we have to physically distance because of public health, we should not be engaging in social distancing. We need to maintain social contact. Humans are social animals. We know, in fact, that social isolation is a risk factor for depression. So I'm strongly encouraging people in whatever form they can to keep contact with others so that they can maintain their mental health. And other forms of avoidance too. If people are engaging in other restrictions, again, I think it's worth stopping and asking the client if there's things that they can do to overcome this. For example, going in Canada, I was saying before this, it's currently very cold, but so going outside for a walk may not be appropriate, but certainly you can do physically distant social and physical activities. And so again, I would encourage those. Clients who are too intellectual or too ruminative, again, I would encourage less of a focus on cognitive intervention, more of a focus on behavioral intervention. And again, for clients who are just not psychologically minded, again, behavioral interventions are often very useful because it's a way of engaging them and getting them to do activities. So some of the techniques we absolutely should be encouraging include things like physical self-care. So helping clients who are depressed to recognize their sleep patterns, to help them regulate their sleep, to look at their diet, hopefully to have more healthy, regular input. There's been a tendency, apparently, in some reports to increase the rates of carbohydrate consumption. So again, it makes sense in some ways you do that because carbohydrates are sugars basically, and they give you a short-term boost of energy and feeling better, but in the long term, of course, they don't sustain. So trying to get people to make more healthy dietary choices is important. And then exercise. And again, the general recommendation that I see now is at least 3 times a week of approximately half an hour a time where you actually get your heart rate and your breathing up. It doesn't have to be dramatically, but you want some kind of cardiovascular benefit from the exercise. So simply lifting weights is not enough. You need to actually do something to get your breathing and your cardiovascular system engaged. 30 minutes, could be walking, doesn't have to be running or something very dramatic, but some kind of regularly scheduled activity. Activity scheduling has always been one of the important features of CBT for depression. Behavioral activation therapy, of course, as a specific type of CBT, only focuses on activity, and so we know that this is highly antidepressant. So we want people to become more action-oriented. Again, one of the recommendations I've been making is that people should every day pick one short-term activity that's going to give them a sense of satisfaction, so completion, and one short-term activity that's going to give them a sense of connection, so social connection. And they should each day also work on one longer-term activity. So either something, again, that's going to work towards a sense of completion or completing a task of some type, or something that they're going to enjoy. And it could be a social contact, it could be a new hobby, it could be singing, again, it could be what the person wants, but prescribing activity, both short-term and long-term every day, so that the person is moving towards goals. And frankly, I don't think it matters if they're made up or if they're arbitrary. Ideally, again, these are things that are important to the person and give them a sense of value. But it's better to be doing something than nothing. Reducing avoidance. Again, the avoidant problem-solving strategy we know is associated with depression. So again, looking for patterns of avoidance and helping the person to recognize and overcome them as much as possible. And then the strategies we use are standard ones. So graded task assignment, building up tasks, that incrementally, looking at the person's goals, their resources, the things that they can actually accomplish, making sure that they're monitoring their success so that, they're not using their cognitive distortion to minimize or not pay attention to the things that they're doing, so they get the sense of accomplishment from the things that they're actually doing. And then if necessary, doing skills training. So again, like I said earlier, some people have been forced into unemployment, and it may be that they hadn't had to seek a position for 20 years. So they may be a bit rusty in terms of how they go about the work situation or looking for work. So again, it may be that they need some skills development or enhancement. I've also heard a specific concern for young adults in particular who are looking for new partners, and how challenging that is right now in the context of COVID-19. So changing the way that people go about looking for relationships and the strategies for doing that. There are a number of online dating sites, for example, now, where you can meet people virtually and then potentially meet them physically later on. So this kind of idea. There's again transitions basically in how things are done. Automatic thought techniques. Again, we tend to use these when there are clear distortions, and there often are negative distortions in the context of depression. So again, some of the automatic thought techniques are very appropriate. It's also helpful when the thoughts are not helpful. So again, I make a differentiation between distorted thoughts, which are obviously not helpful, and non-distorted but not helpful thoughts. So again, sometimes depressed people are facing realistic problems and they have negative thoughts, and the negative thoughts may not be helping them to solve the problems or manage the issues they're facing, but they might be quite realistic. And in fact, in the current situation, I would say that we've seen an increase in the unhelpful but realistic negative thoughts. So again, we probably need to focus a bit more on them in terms of our current interventions. If you find that somebody is extremely self-critical or self-punitive, of course, you want to address them, and especially if they veer in towards self-harm or potentially suicidal behaviors, you need to address these kinds of thoughts very quickly. And again, just a quick word that this is typically related to hopelessness. And again, we've seen increases in rates of hopelessness, increased number of calls to suicide crisis lines associated with hopelessness. So again, if you recognize those thoughts in your clients, they do need to be addressed quickly. And then finally, we want to promote flexibility. We want to help clients to be able to see situations from different perspectives that hopefully then give them a chance for solutions. So when I think about working with negative automatic thoughts, I think about three sort of technical questions as a clinician we deal with. One is the evidence, and sort of helping clients to look at whether their thoughts are realistic or whether or not they're perhaps skewed towards the negative or biased towards the negative. So these are a whole host of evidence-based interventions. And some of these certainly are appropriate during the pandemic. I'll talk about it in a second. The second is there an alternative? So basically, is your thinking helpful? Does it work for you? Or is there a different way you could look at the situation that would be more helpful? And these questions, I think, are in particular useful right now. And then the last is the implications questions, what I sometimes think about as the so what question, which is even if the situation is as bad as you see it is, and there is no more different way to look at the situation, do you still have to be depressed? This question typically gets you into looking at core beliefs or the meanings that people draw from situations, and I'll talk about that. So evidence-based strategies, and again, I won't go through these because of time, but there are many of them. And these are standard ones, looking for cognitive distortions, looking for misperceptions of situation that are more negative, and the standard CBT techniques work, I would say. Using a thought record, helping clients to look at their thought, look at the evidence, and bring their thinking more in line with the evidence, especially if you recognize distortions, would be a standard technique. This can be easily applied virtually, like using distance. You can share thought records electronically, and you can help clients to do this work. Alternative-based methods are also definitely possible. So this is things like changing labeling. This is a horrible situation. This is the worst ever, to something, again, that this is a difficult situation. This is something we have to get through, and helping people to come up with more functional or more adaptive ways to think about challenging situations. To look at reasonable and helpful alternative thoughts to the alternatives, to the negative thoughts rather. So I definitely don't, and most CBT for depression people don't encourage mantras or just simply positive statements, but looking at things that fit their situation and that are going to help them to approach a problem and work on or solve it rather than avoid it. So looking for ways that they can speak to themselves that is going to be more functional or more helpful. A really important skill right now, I think, is to help clients to be more gentle with themselves and to accept the limits that we're all facing. So it's not pleasant right now to have to be locked indoors and to do physical distancing. But I think if we can be more accepting of the situation, I think, again, we're going to be less distressed and probably feel better because of it. So again, I think, sort of moving towards acceptance kinds of interventions right now in particular makes some sense. And I'll come back to this theme. Memory aids, of course, can always help people to remember positive ways to think or less negative ways to think. So again, using cue cards or memory aids, if that's going to help people. And one that I really like, a technique I like, is the rational role play. This is where you have the person express the negative thought, and then you teach them these strategies for speaking back to their negative thinking when it emerges. So it's not a person role play, it's a role play about the thoughts and the responses. And the responses can either be evidence-based, so helping the person to recognize more accurate ways to look at a situation, or they can be alternative-based, so helping the person to come up with more functional, more adaptive ways to respond to negative thinking when it emerges. And again, in virtual therapy, you can certainly help people practice the responses to negative thinking. So the third category then are belief-focused or core belief or schema-focused kinds of interventions. And generally we use these when we're promoting a case conceptualization, when we want to consolidate or provide a framework for the other kinds of interventions we're using, when we want to integrate our past history of the client, how they develop their core beliefs with their current work, and to reduce risk of relapse. And I'm going to say something I think that's a bit provocative now, which is that even though theoretically you could work on change of core beliefs for people with depression, I would argue that generally speaking, the pandemic is probably not the right time to do this work. So I think, like it says here, I think the pandemic may be a time to reflect or think about the past or to set new directions. But I would argue that you only would want to do that if their current functioning is pretty positive. So if they're coping pretty well in general, and then it seems appropriate to focus on core beliefs that might be driving or promoting some of the depressive tendencies, then it might be appropriate to do core belief work. But I would suggest in general, because the pandemic is associated with increased external factors, especially, like I said, loss, that depression is in fact almost a normal response to loss. And so trying to work on core belief change may be less indicated. So again, I don't have any data to support this position, but I think if you look at the risk factors, the logic makes sense. So that being said, there are a number of techniques, and again, I'm not going to go through them because of time, but the standard techniques for doing change-oriented core belief work in depression still work. So looking at alternative core beliefs, having the person think about short-term and long-term advantages of the old core belief and a new core belief, getting them to implement strategies based on the new core belief and try them out, certainly I think can be used. But again, I think these are much more difficult to do in the context of COVID-19. So my bias would be to sort of steer away from these kinds of interventions, at least for the time being, until they may become more relevant. What I think does make more sense is acceptance-oriented interventions. And here I think these have great value potentially in the context of COVID-19. So things like helping people to recognize distress when they have it, or negative thoughts and negative feelings, and learn how to sit with that. So mindfulness-based kinds of interventions, for example. Learning how to cope with difficult people or difficult situations. So for example, if somebody's in a relationship where they're not able to physically distance, because of the living arrangement, figuring out some effective strategies for managing or living with that person in a safe and harmonious way if possible. Building resiliency. And again, I think part of this is eating well, exercising well, building new activities, thinking about the things that you would like to do and doing them. I've been encouraging some people to develop new hobbies, for example, if they have the time and the interest to do that. Partly, again, honestly, as a way to pass the time, but again, to do it in a way that you feel good about yourself and that you're not just simply waiting for the end of the pandemic. Developing other resources and interests, so hobbies, for example, if the person wants to do it, and generally practicing mindfulness skills. This is a good time, I think, for people that might want to do yoga or mindfulness meditation, if they can learn, if there are access to them online. This is, I think, a reasonable time to encourage those kinds of activities. Few things, I'm mindful of our time here today. In fact, just a few last slides, I'll just mention some of the technical aspects of CBT. When we're dealing with depressed people, of course, there are a number of issues we have to manage. So we need to always, of course, maintain our ethical standards as practitioners, so getting informed consent. This is a bit more complicated in the context of COVID-19, but I hope you're all doing that. My strong bias, especially when you're working with depressed people, is to maintain visual contact with the client. So using technology like Zoom or Skype, or there's a whole host of different providers now that are out there, so that you can see the person. Try not to have one where the client is on voice only, so telephone or non-video based interventions, because it's important to see the client and to see how they're responding. Sometimes depressed people can be quite agreeable verbally, but if you see them, they're downcast or they're looking discouraged. And so you can pick up the discrepancy between the verbal and nonverbal communication. Make sure that clients understand the privacy limitations of the systems you're working on. So for example, Zoom technology is based in the United States, most of the servers. And so these are subject to the Patriot Act. And again, some people don't understand that kind of issue. So make sure that people understand as best is important for them about privacy issues. With depressed patients in particular, I would structure shorter sessions and more frequent if you can, so that you are trying to have a comparable amount of therapy, but perhaps in smaller chunks. We've all heard, of course, about Zoom fatigue, or the difficulty it is to maintain good contact while you're in technology. And so respect that and recognize it, and try to, again, adjust if you can the sessions accordingly. What this means as a practitioner is you probably need to be more structured. Again, if you have a shorter session in particular, you're probably going to want to have less chit chat, or less beginning and less ending of the session, and be more focused on the work that you do. You want to, of course, ensure, if possible, that the client is doing assignments. So if there are homework assignments, for example, they can still send you their reports. If they have the ability, they could scan thought records, for example, and send them to you. If they have computers that they're working on, again, so technology can be a limiting factor, but if they're working on computers, they could share their thought records with you potentially on screen and so on. So again, using the structure as best you can to replicate the interventions that we use would be very helpful. Try to make sure, as we would always, that the homework assignments are clear and manageable. And again, here, I guess the main thing I'm thinking about, whereas you might have before with a depressed person encourage them to go out for a walk 3 times a week, there may be physical limitations right now for them to do that, depending on local limitations. Some places I know have quite severe lockdowns, for example, so it may not be as possible. So take into account what you need to adjust. Using screens, I already talked about this idea that you can do this in different ways. At the very least, I would encourage all of the practitioners who are watching this to have their own ability to share screens. So even if the client doesn't have the technology, but if you're on a computer system, then if you can share a screen, you can show them a thought record and show them how to do it through technical means. Better, of course, if they can get it as well, if you can share it with them and if they can complete it. And again, there's no reason why a lot of the regular methodologies like paper forms or electronic forms can't be used. I always recommend doing progress monitoring with therapy cases. The tool that I've gone to in the last number of years is the PHQ-9, which I believe is pretty commonly used in Latin America. It's a 9-item measure. It's a quick assessment of depression. You can share it electronically. It's not copyright, so you can share it. It has public access, and you can monitor progress. If, again, the client doesn't have the ability to do monitoring themselves, you can actually share the screen, again, when you talk to them, and they could fill out the questionnaire right then and there. Fill out the 9 items. It takes a very short period of time. You should think about using pseudonyms or passwords if you're sharing documents. Again, there are privacy issues, so again, rather than using the actual name of the client, you might encourage them to use a false name so that when they share the documents, it's not clear who they're coming from. Always, we would do this normally, but especially in the context of COVID-19, you need to make sure that the client has the time. Fortunately, most of us have more time in a sense because of COVID-19, but also that they have the energy to do the assignments you're talking about, and they have the resources. And again, financial resources right now are limited. Some people have limited ability to get out of the house and do things. So again, be sensitive to those issues and make sure that the assignments are relevant. The other thing, of course, in depression is that there is a risk of suicide, and suicide screening is somewhat more difficult during COVID-19. But again, I think you need to be ready and prepared to ask the questions related to suicide. In fact, one of the things you can do, which is a nice feature of COVID-19, is you can easily have sheets beside your computer screen to help you get prompted to ask different questions, so to do appropriate screening. And then getting access to resources, of course, can be more challenging, but many of the public health issues and emergency services are still available and still operating. So again, be ready if necessary to intervene with suicide. Just a few last comments. Generally speaking, I think the validated treatments for depression that we have in CBT work. There's no reason to think that they don't. I'm looking for some well-done randomized trials in COVID-19 for depression. I haven't seen any emerge yet, but I do know that some are ongoing. But again, what I hear anecdotally is that the treatments continue to work. And if one validated treatment doesn't work, try another. Because again, from a sort of systems perspective, CBT is certainly one evidence-based treatment, but there are others for depression as well. We also know from a sort of general model perspective that if one treatment doesn't work, another one may, and that for more severe cases, the combination of pharmacotherapy and evidence-based therapy like cognitive behavioral therapy can in some cases benefit more. Not for less or even moderately depressed people, but for the more severely ones. Ideally, again, people are being screened and are getting quick access to therapy. One of the virtues, again, sort of paradoxically perhaps, is that in some ways people can get quicker access to therapy now because of COVID-19, rather than having to physically go to places and physically be in a clinic. So again, the earlier you can get to someone and provide care, the better. If you can, focus on relapse prevention. Again, I would argue this is going to be a little bit more difficult, partly because the risk factors are changed in the last year. But if you can, again, focus on general coping strategies and general techniques to reduce the likelihood of future depression. Do your risk assessments if necessary. And for those of you that want further reading, I always recommend the NICE guidelines. So this is the last bullet on this slide. These are based out of the United Kingdom. They're a very comprehensive, evidence-based set of guidelines for the management of mental health and other conditions as well. In fact, it cuts across the entire range of health disorders. But there are NICE guidelines. National Institute for Clinical Excellence is what that stands for in the United Kingdom. And again, if you want to go look at the evidence-based recommendations that they have for major depression, you'll see that CBT figures very prominently. So again, I strongly recommend that these get as widely used as possible. So with that, I'm looking at the time again. I'm just going to stop with my comments. I want to thank you for your time. So gracias, obrigado, and I'm happy to have questions.
Thank you so much, Keith, for sharing so much knowledge, and congratulations on your brilliant presentation. Now we will have the opportunity for some brief questions and answers session. Actually, we would like to hear you a little bit more about the evidence based relation. At the beginning, you presented, you commented that we should try to work with the identification of evidence, and we would like you to hear you a little bit more how we could do this. The evidence in relation to the negative thoughts. How could we assess this and work with this with the client?
Surely, thank you. So again, evidence-based interventions in depression are very common because we do know that many depressed individuals probably had a pre-existing bias towards focusing on the negative and maybe paying less attention to the positive. And as people become more depressed, this tendency can become even stronger. So, the bias towards cognitive distortions. And so what we often will do is we'll spend some time relatively early on in the course of therapy talking about this tendency. And especially if we see the client doing these things. So if we see the client perhaps giving too much attention to a negative event, or if we see them blaming themselves in a way that seems perhaps inappropriate or disproportionate to the situation. So if we see distortions actually sort of playing out, we'll probably introduce this idea that many people who are depressed have these patterns. We may spend some time doing education, so telling them about what different patterns of distortions might exist. And of course, if we've seen some with the client, we usually will include those so that we try to make it relevant to their life experience. We might even share with them documents that give a list of distortions so that when they start to track their negative thoughts on the thought record, we can then link back the thoughts that we see and see whether or not some of these are potentially distorted. So this is sort of an educational piece and sort of an awareness piece, building more insight from the client. And the intervention part is helping the client to recognize that if the thoughts are distorted, perhaps there's a more accurate way to think about the situation. And this is where it gets tricky because, of course, many clients don't have different ways to think about a situation or new ways to get evidence. So here you might need to have them do things like ask other people in the situation, how did they see it? So look for independent sources of information. You might get them to think about their history, whether or not they've tended to have these kinds of biases in the past, and whether or not it hints that it is a bias. It's not necessarily realistic. You might get them to go back if it's a written document, for example, and to reread it or to share it with somebody else and get a second opinion, as to whether or not the interpretation is justified. So again, there are a number of techniques. It depends partly on what the specifics are, but basically comparing the reality, so to speak, or something that's closer to the real world versus the perception that the client has, and trying to bring those as close as possible. It may be, again, that you can help a person reduce their distortion, but even at the end of the day, they're still seeing it more negative than you might like. Some of the techniques that are otherwise possible would be for you as the therapist to suggest different ways to look at the situation. I'm a bit reluctant to recommend that because, of course, you don't want to set yourself up as the expert and to tell the client how to think about the situation because, it's his or her privilege. But again, you could suggest and see if they're willing to try out these alternative ways of thinking too. So there's a number of different techniques that you can use to address distorted thinking.
Perfect. Thank you. We have some questions more. Shall we?
Please, yes.
How could we work with the patient, the most negative view of the future because of the uncertainty and everything that is related to the pandemic?
Yes.
For now?
Well, yeah, right from the very beginning, when the pandemic first broke, I said that there are 3 psychological factors associated with the pandemic that are going to be the most challenging: unpredictability, uncontrollability, and personal importance or salience. And of course, these are the 3 psychological factors that predict anxiety. And so we saw anxiety rates jump dramatically in the early days of the pandemic. I had thought early on that as the pandemic went along, anxiety rates might start to go down as we learned more about the virus itself and how to respond to it. But the truth is, uncertainty maintains. Right? We don't know still much about the virus. We have the new variants, as they're called, leading us to question the data that we have. We're still learning about the vaccines and which ones might work and where and with which populations. So there's still a lot of uncertainty. And of course, if we don't have good certainty, it's hard to know how to respond. So again, my general thought about the future is to try to not ignore it, of course, but to pay less attention to it and try to focus more on current kinds of things that you can control. So things like I said, doing regular exercise, regular sleep, starting new hobbies or new activities, maintaining social contact. These are more momentary or more immediate kinds of issues. And then for the future, I think our general focus should be more one of trying to promote acceptance. That have to faith, their confidence that the public health measures will have benefit, that the vaccines will eventually start to reduce rates of COVID-19, and so to focus less on the future. Like I'll just say in my own life, for example, one of the things I enjoy is travel. And so, of course, right now that's just not possible. So I do engage in the fantasy every now and then about travel and, think about it, but I'm certainly not making formal plans. So again, I think you can indulge some of these ideas, but accepting the reality that right now formal planning doesn't make sense. So it's a way of sort of shifting the focus of attention to things, again, that are more immediate and more manageable. So, but I think this is one of the big challenges for sure in COVID-19 is the future and what will the future hold. I've seen various, again, descriptions that, this may take us years before we get back to normal functioning, whatever that is. So, and again, there's a lot that we don't know. For example, education. We know that many universities right now are closed and are doing virtual education. And I've heard some talk that even once the pandemic is over, a lot of universities and schools will still use blended learning. Or conferences, conferences like this one, of course, have had to move to a virtual technology. And I've seen some discussion now that even when the pandemic is finished, whenever that is, that some conferences will maintain a blended format because there are some advantages, in fact, from COVID-19 and the ability to reach larger numbers of people. So some of what we think about in terms of normal or the way things used to be may never come back. So again, at this moment, I would suggest focusing less on that and focusing more on what we can control.
Perfect, thank you. The last one. You gave us some suggestions about assessing suicidal risk. Could you talk a little bit more about how we could, which procedures you would recommend to deal with suicide risk in this blended situation?
So are you talking about doing assessment or intervention or both?
The intervention. You did talk a little bit about assessment, and we would like you to talk a little bit about the intervention.
Right. Okay, great. So just very briefly, again, when I think about suicide assessment, there are two broad domains I assess. One is intent, or the desire to live versus the desire to die. And then the other is lethality. So do you have access to a method, and how likely do you use it, and so on. And I always assess intent first, because in fact, that's the more critical variable. If people have high intent, they can find a method. So again, the methodology is important to know if the person has access, but the intent dimension is more critical. In terms of intervention, though, what I would say is that certainly in North America, I don't honestly know in all of the countries of Latin America, but I do believe that most of the typical techniques that we have for intervention remain. One of the big challenges, of course, is if you're doing virtual therapy, unlike being in the same office, is, it's harder, of course, to know exactly what the person is experiencing, and then to potentially support them if they need to go to the emergency room or to get, potential hospitalization. So figuring out where the person is an important thing. And again, if you're working with somebody who's depressed, and if you know that they have tendency towards suicide risk, I would always start the session by asking them, where are they? So that you know physically, their location. And again, recognize, and again, in the informed consent, you would normally, of course, tell them that one of the potential limits of confidentiality is if you're engaging in self-harm or harm towards others. And this would, again, depend somewhat from country to country, depending on the local laws. But if that is the legal standard, then you would warn them that self-injury or risk of suicide is grounds for potentially breaching confidentiality. And then basically, if you understand that they've become an immediate risk to themselves, you would tell them that. Once that's your opinion, then you do need to take action. And so the action could be helping the individual themselves get to an emergency service where they can be assessed. It could be calling a family member who may be in the same area and getting them engaged. It could be, certainly in Canada, we can call the police and get them to take the person to an emergency service, or we can call emergency services directly, 911 in Canada. So there are different venues or ways to get people to care. One of the real problems we have in general, certainly this is true in Canada and the United States, is that people who go to the emergency room for self-harm or risk of self-harm often don't get treated very well. I don't know in Brazil or other countries, but oftentimes they get put in the corner, if they're not actively, if they've already not injured themselves. And so they may not get long-term care. And rates of hospitalization for mental health issues in the COVID-19 context have gone down. So hospitals are generally less likely to admit people for risk of self-injury than they were before the pandemic. And part of that is just risk of transmission, people trying to keep people out of hospital as much as possible. So it's more likely, in fact, that people are going to be left at home or left out of hospital, basically, if they're self-injurious. So this goes back to my earlier comment, potentially about having shorter but more frequent sessions. So again, I think as a healthcare practitioner, one of the things you can do is make sure that you have regular touch base with clients if you can. And even if they're shorter appointments, at least let them know that you're monitoring and asking the right questions.
Perfect. Thank you.
Thank you.
Well, we could stay here listening and learning from Dr. Dobson for a long time, but unfortunately it's necessary to close our session. Keith, I have no words to thank you for the availability, for your generosity. It's always a pleasure to hear you.
Thank you.
Thank you so much.
And now, I wish you all the best. I've actually been in touch with some colleagues in Latin America over the last year, and I understand that there are a lot of challenges, of course, in many countries. And we are unfortunately still in the middle of this global pandemic, so it's going to take some months. And so, again, I encourage everybody to hang in there. Both practitioners and, of course, clients. But all of us are in this together, and I'm confident that we will get out of it eventually. But it's going to take some time yet.
Thank you so much, Keith.
My pleasure.
Now, let's continue with our symposium schedule. Enjoy.